Our next talk is Kristin Highland. She was at MUSC, but now she's a staff physician in the Cleveland Clinic. She received her medical degree at Indiana, her internship in MUSC in South Carolina and Charleston, was a fellow in pulmonary and critical care and rheumatology and immunology at MUSC. And she's been one of the best doctors ever since 2004. She came to Birmingham, gave us a talk, and I said, can you come here, because she's such a great teacher. She's going to talk today about CTD-associated interstitial lung disease. Kristin.
So I'm a much better pulmonologist than rheumatologist. I actually thought I had musculoskeletal back pain for the longest time until I recently had a 2-centimeter kidney stone, and so I now no longer have back pain. So I'm sticking to above the diaphragm, which I do a little bit better. But I did take my rheumatology boards, and when I was studying for them, I had one of the more commonly used review books, and the opening paragraph talks about the origin of the word rheumatology and how rheuma is an ancient humor that spreads the brain down to the body and creates problems, and is derived from the Latin root phlegm. So is a pretty intimate relationship between rheumatology and pulmonary, and I've found that I've gotten quite a few referrals to deal with that relationship, and many of my patients have underlying interstitial lung disease. I have a number of disclosures, none of which I think are relevant to this talk. So when you think about interstitial lung disease as a whole, I tell my patients there's more than 300 causes of interstitial lung disease, and I list asbestos and bird fanciers. But 13% of the total population of interstitial lung disease or so has an underlying connective tissue disease. And so when I'm educating pulmonologists and pulmonary fellows, I emphasize the importance of doing that very extensive review of systems and extensive physical exam. And it's not uncommon that I walk into the room and, say, oh, how long have you had scleroderma? And the patient looks at me and goes, huh? And when you look at the breakdown of these patients with interstitial lung disease, you can see that the majority of them have rheumatoid arthritis, and that's probably because the majority of our rheumatologic patients have RA. This is followed by scleroderma and our dermatomyositis, mixed connective tissue disease. And I think this category of lupus is a little bit overrepresentative. When I look at the patients that I see in my clinic, I would say that they kind of favor more the scleroderma and the dermatomyositis, polymyositis populations. And interstitial lung disease, along with pulmonary hypertension, really are the leading causes of morbidity and mortality in our connective tissue disease patients, as you can see by this pretty famous slide, if you've ever attended a scleroderma talk, that kind of emphasizes this point. And it's important for us to kind of figure out what kind of underlying connective tissue disease is behind the interstitial lung disease, because those patients with scleroderma-associated interstitial lung disease have a much favorable prognosis to patients with non-scleroderma interstitial lung disease. And this is probably driven by those patients with rheumatoid arthritis who tend to have a worse histopathology, one more associated with usual interstitial pneumonia, where scleroderma is more often non-specific interstitial pneumonia. But the challenges are that connective tissue disease, ILD, can be indistinguishable from our idiopathic interstitial pneumonias. And the interstitial lung disease may precede other manifestations of